Okay, so we're going to talk now about fetal monitoring. We talked about putting the patient on the fetal monitor, but we're going to talk now about how to know what that monitor says or what it means. First of all, monitoring can be with an electronic monitor, which is what most of us are familiar with, or we can actually use our hands and some auditory equipment to do intermittent monitoring. So we're going to talk about that intermittent first. We can do intermittent monitoring with auscultation and palpation. The fundus is going to be palpated to count the frequency of contractions, so how far apart those contractions are, how long they last, how intense they are, and the resting tone, or how much the uterus relaxes between contractions. So when we're measuring contractions, we want to know how far apart they are, so how frequent, that's frequency, how long they last, so how long on average they last, how strong they are, and we want to know that the uterus relaxes completely between. Okay, we can do that by palpation. The fetal heart rate can be auscultated. Sometimes you can get a good enough position that you can use a stethoscope. A lot of times it's harder to hear with the stethoscope, so there are some specially designed fetoscopes, or a Doppler can be used. So let's look at a couple of different designs for fetoscope. This is called a Pinard Feudoscope, and this is placed on the abdomen over the area where we would expect to hear fetal heart rate best, and it's going to amplify the fetal heart rate enough that we can actually hear it well. So now we're going to look at a different type of fetoscope. This is one you may have seen on TV. Again, this is going to amplify and transmit the sound, but this uses the frontal part of the head. It uses the bones in the skull of the listener to help transmit that sound and make it easier to hear. So those are two different options for fetoscopes. Okay. We can also use an electronic fetal monitor intermittently. It can be put on and then taken off to let the patient move around and put back on. And sometimes you see that done in the hospital. You'll see intermittent monitoring by palpation and auscultation, either with a Doppler or a fetoscope of some type in home and birth center births more often. You'll see midwives use those techniques. How often should this be done? There's not a lot of research. There are some guidelines. It should be done at least hourly until the patient's about 4 centimeters, then every 15 to 30 minutes until they're about 6, every 15 to 30 minutes throughout active labor, every 15 minutes during passive descent. And that means when they're completely dilated, but they're not actively pushing. Every 5 to 15 minutes during active pushing. So if in a low risk labor, there hasn't been shown to be any difference in outcomes between this and continuous monitoring. The reality is, though, if there is a bad outcome and there's not a continuous tracing in the US, in our culture, that's expected. And so patients are more likely, or they're believed to be more likely to sue, and there's a potential opening for that lawsuit. So the continuous fetal monitor is as much a legal record as it is for patient protection. We need some way of monitoring, but in low risk labors, intermittent monitoring is as effective at catching complications as continuous. The continuous monitoring is more often used just to limit that legal risk. The other thing about intermittent monitoring is that it really requires one-to-one staffing. And a lot of units are not staffed that way. If we have continuous monitoring on every patient and they have centralized monitoring, so the monitor can be seen at the nurse's station, that allows each nurse to take care of more patients because as long as someone's there to see any changes on that monitor. So we're going to move on now to the external fetal monitor. Electronic fetal monitors can work in both modes. You don't have to have a whole separate monitor to switch from external to internal. So that's the first thing to know. The external fetal monitoring machine is the same. External and internal refers to how we're actually measuring the data. So we're going to look at the external monitor equipment. Okay. These are, this is one example. They don't always look just like this. We're going to monitor two different things with external fetal monitoring. Uterine activity is monitored with an external pressure sensor. It's called a tocodynamometer. You will hear the nurses talk about a toco, okay, that measures pressure. This button here, and it may look different on different models of monitor, but this button responds to pressure and transmits a signal that is recorded. And we're going to look at what that recording will look like in just a few minutes. So if I'm monitoring externally with, I'm just monitoring pressure, if that patient changes position, it may register as some kind of movement on the monitor. It may actually change the baseline of that tracing because it changes the continuous pressure. If that patient coughs or laughs or throws up, it may show a change in pressure. If the fetus changes position, it may change how those contractions are being picked up because it can change the pressure on this monitor. If I put this monitor on tighter, I'm going to see bigger hills on the tracing. If the monitor is on loose, or if it's on a part of the abdomen that's not putting pressure with the contraction, it may not show anything. So those are the limitations of external fetal monitoring. We would want to use this if because it decreases the risk of infection. For some people, it is more comfortable. For some people, it is less comfortable than internal monitoring. That's kind of an individual thing. But it decreases the risk of infection. The longer we use this, the less time we have with something going into the uterus. We would definitely not want to use, we have to have broken water. We have to have ruptured membranes to put in an internal. So we definitely want to use this until their water is broken. This is the external ultrasound monitor, fetal heart monitor. So one part of this measures the contractions. This part records fetal heart tracing, and it uses ultrasound technology. So it has to have ultrasound gel. It's going to pick up best if it is aimed toward the fetus's back. And sometimes the fetus moves, sometimes we lose the tracing or can't pick it up as well, especially if they're a little smaller or gestational age is different. So external ultrasound monitor, sometimes we can get a really good tracing, sometimes we can't. One other thing about the external contraction monitor, we cannot tell how strong those contractions are at all. So the ultrasound can also pick up the mother's heart rate. And I've seen this happen. This was a patient that had the flu and had really high fever, and we were monitoring, and the heart rate on the ultrasound was in the 120s. And so the assumption was made that it was the fetal heart rate. Well, it turned out the mother's heart rate was in the 120s and the ultrasound was picking up the mom. When they moved it and picked up the fetal heart rate, it was in the 180s. So we need to make sure that we're not picking up a maternal heart rate. And one way to do that is listen and palpate the maternal pulse at the same time. There actually is a new monitor that uses 5 electrodes on the abdomen, and it transfers the data via Wi-Fi or Bluetooth, and it actually may allow more mobility and may have a little bit better transmission of data. Okay, so that's external monitoring. The next thing we're going to talk about is internal monitoring. So this is a cross section of what internal monitoring would look like. The pressure inside the uterus is measured at all times by an intrauterine pressure catheter, IUPC. You will hear the nurses say something about an IUPC, okay? And the fetal heart rate is measured by an electrode that is directly attached to the scalp. And we're going to look at what those look like, okay? Some of the benefits, this is much more accurate than external. Sometimes if we can get a good tracing with external, it's pretty accurate, but internal we can get a more accurate reading if we're having a hard time getting a good tracing. But IUPC gives us the actual pressure of the contractions. So we can measure the strength of contractions with the IUPC. We cannot with an external monitor. That's really important to remember. It does require rupture of membranes. The patient's membranes have to be ruptured for this to work. So it requires rupture of membranes, which increases the risk of infection. And then we're adding things into the uterus, so that further increases the risk of infection. So it also, the fetal scalp electrode makes a tiny wound on the fetal head. And so there's a very slight risk of infection to the fetus at that site. Also, if the mother has any bloodborne illnesses, they can be transmitted through that wound. So I'm going to stop share, and we're going to take a closer look at those two apparatus. Okay. This is a closer look at an intrauterine pressure catheter. This is the pressure sensor. This is going to be connected to the monitor. And again, the same monitors used, they just connect the catheter when they change it. So this is what an intrauterine pressure catheter looks like. This is what the fetal scalp electrode looks like. And you can see the size of the hands. Right here at the end is where there's a tiny coil, and I'm going to show you a close-up view of that. I just wanted you to see this one so that you can see the size of it. It's actually a very tiny wire. Okay, so this is an enlarged view so that you can see, and this tiny wire is actually twisted under the or into the scalp of the fetus, and it transmits the heart monitoring directly. Okay. Okay, so when we are monitoring the contraction pattern, we are looking at resting tone, we're looking at frequency, strength, and duration of contractions. Even if we have an internal monitor, we're always going to palpate, because I want to make sure that I'm also palpating that abdomen to verify the strength of those contractions. We're also assessing the mother's response to those contractions. How are they tolerating them? And we're going to look at something called Montevideo units that sometimes you'll see providers use. So we're going to focus just on the contraction part. That's this bottom part. Ignore the fetal part for right now. We'll get back to that in a little bit. Okay. So the resting tone, if this is an external monitor, we cannot tell you about resting tone. Remember, I could just make the belt looser and drop that resting tone. If this is an internal monitor, the resting tone is about 10 millimeters of mercury. If it's external, I'm going to palpate, and I'm going to say if that abdomen is soft between contractions. Okay, so resting tone, we want to palpate if this is external. If it's internal, that's 10 millimeters of mercury. The contractions, let's count how far apart they are. Now, these dark lines are a minute, and the lighter lines are, it looks like these lighter, though, there's 20-second lines, and then there's even lighter ones that are 10 seconds. So wasn't used to that. All right, so dark lines are a minute. 1, 2, 3, 4, 5, 6, 7. So about 7 minutes between these two contractions. And ideally, we would have a longer strip so we can look at, they're about every 7 minutes. We want at least a 10-minute strip usually, which I think this is a 10-minute. But if we're having really spaced out contractions, I want to know if these two this close together are an anomaly or all of them about every 7 or 8 minutes. So these are about every 7 minutes. If we have more, we're going to get a range. Okay. We want to know the strength. I cannot tell you the strength if this is an external monitor. I'm going to have to put my hand on the belly palpate and say, is it mild, moderate, or firm? Okay. If this is an internal monitor, the strength is up to about 70 millimeters of mercury. Okay. And then duration, 10, 20, 30, 40, 10, 20, 30. So about 30 to 40 seconds long. So I would chart this. If they have an internal monitor, I would chart contractions noted every 7 minutes. This is an internal monitor. Contractions noted every 7 minutes to 70 millimeters mercury with soft resting tone or with resting tone at 10 millimeters of mercury. Contractions last 40 to 50 seconds or 30 to 40 seconds, I think it was. Okay, so I'm going to say how far apart they are, resting tone, how long they last. And then I'm also going to palpate. So I'm going to say contractions palpate moderate with soft resting tone, assuming that's correct. Now, if this is an external monitor, I'm going to say contractions every 7 minutes. And then I'm going to talk about the palpation. Palpate moderate with soft resting tone. Contractions last 30 to 40 seconds. So I've got frequency, duration, frequency, strength, duration, no matter what. Okay. And resting tone. Now, if this is an internal monitor only, you cannot calculate Montevideo units with an external monitor. If this is an internal monitor only, sometimes if the provider is trying to determine whether the patient's labor has stalled out or is not progressing, the first thing to look at is, are they having enough contractions? So with an internal monitor, are they having adequate contractions to cause cervical change? If not, that's what they focus on, try to make more contractions happen. If they're having adequate contractions and they're still not progressing, then they might look at something else. So one way to measure adequate contractions is Montevideo units. Montevideo units are the difference in peak uterine pressure and resting baseline for every contraction in a 10-minute period. So this is, I think this is 10 minutes. If not, it's close. We would do a 10-minute strip. And then we count from the baseline up to the peak of every contraction. So we start at 10, so we skip the 10. 10, 20, 30, 40, 50, 60, 70, 80, 90, 1, 10, 20. So there's 120 Montevideo units. 200 is considered adequate. If it's less than 200, then you don't really expect cervical change, or you can't say that they're not having, they're not progressing because there's not enough contraction. Okay. All right. So that is how we document contractions, or how we assess contractions. The next thing we're going to look at is how we monitor the fetal heart rate. The first thing that we look at for fetal heart rate is the baseline. Okay, and we're going to do the baseline in this video, and then we're going to come back and look at something else, at other pieces of that in the rest of the videos. So if I'm going to monitor the fetal heart rate baseline, we're going to go back to that same video. The fetal heart rate baseline is the average of where that heart rate is falling. So if you kind of draw an imaginary line down the middle of all these squiggles, squiggles are good, by the way. Fetal heart rate baseline is around 155. Okay. Somewhere between 150 and 160, right? So around 155. The normal fetal heart rate baseline is 110 to 160. Remember, it can be higher at preterm and lower postterm, but we want to see between 110 and 160. That's what we'd like to see. We also want to monitor that baseline for changes. Maybe when they came in, the fetal heart rate baseline was 120 something, 120s, and now it's in the 150s. That's a significant change. So we've got to monitor for changes. Even if it's within the normal range, if they're having changes, we want to look at that. So we're going to look at fetal bradycardia first. Got to switch my strip over. Okay, bradycardia is less than 110 beats per minute. This fetal heart rate is sitting at 100 beats per minute. This is bradycardic. There are some other things wrong with it that you're going to be able to determine before we finish this today. But bradycardia is what we're looking at now, 100 beats per minute. I have seen babies that sit in the 100s and they do okay. So it's not like this is an immediate C-section, but this is something we need to be watching. Okay, so heart rate under 110 is bradycardia. That can be from a, sorry, let me make this, let me get rid of this. That can be from a fetal cardiac anomaly. They can have some kind of cardiac problem. It can be from infection. It can be because the mother's blood sugar is low. If the mom's hypoglycemic, you may see bradycardia. It can be because the mom is hypothermic. Okay. Most common reason I've seen it is a post-term fetus. And when you see that there are some other reasons that a post-term fetus has some risk. So if you see a low baseline like that, you're just alert and paying attention to what's happened. So we talked about low. Now let's talk about high. Fetal tachycardia. It's funny to be talking about a heart rate of 100 as being low because that's considered tachycardic for adults, but 100 is bradycardic for a fetus. So now let's look at tachycardia. Fetal tachycardia is greater than 160 beats per minute. Okay, and you can see this is hovering around 180. So this fetal heart rate baseline is 100. Okay. Or sorry, 180. The other one was 100. This one's 180. So what can cause fetal tachycardia? It can be stress or distress. It can be if the mother has, if the mother or the fetus has an infection, if the mother has fever, it'll go up. Fetal anemia. Remember that everyone gets anemic or gets tachycardic when they're anemic, so the fetus can too. So fetal anemia. There are some meds that have an adrenergic effect, and then if the patient has used drugs that have an adrenergic effect, that can cause tachycardia. So I want you to think for a second about what drugs those would be and what meds those would be. Okay. Preterm fetuses may have a higher fetal heart rate baseline. Okay, so that's baseline stuff. Now, in the next video, we're going to move on and talk about variability.